Now, this presentation focuses on insulin therapy in the elderly. While insulin remains a vital treatment for older adults, its management brings unique complexities in clinical practice. So let's begin. So here we have two different elderly patients with two different scenarios. Case 1, 76-year-old male, 8-year diabetes history, admitted with congestive heart failure on glargine 35 units daily. Lab shows moderate glycemic control with A1C 7.6%, renal function mildly impaired with eGFR 55, capillary blood glucose log revealed both hypo and hyperglycemia episodes. The key issue here is glycemic variability with cardiac and renal comorbidities. While case 2, a 68-year-old male, 25 years diabetes history, diabetic foot infection with osteomyelitis, on metformin and glargine 22 units at bedtime, poor glycemic control with A1C of 8.8%, blood glucose of 264 milligrams per deciliter, renal impairment at eGFR 40 with key issues infection, poor control, and declining renal function. And we would like to ask the question, what is the best treatment option for glycemic control for each? Should both patients be treated with insulin and to the same glucose target? So the diabetes is an important health condition for aging population. The incidence of diabetes increases with age until about 65 years, after which both incidence and prevalence seems to level off, and this is according to US CDC. As a result, older adults with diabetes can be grouped into two categories: those with incidence diabetes, and that is diagnosed after the age of 65, and those with long-standing diabetes, which began in the middle age or earlier, and these individuals live longer with the disease and eventually reach old age, a pattern I refer as carryover diabetes. So what's the implication? The implication is that recent onset diabetes in older adults may present different clinical challenges compared to long-standing disease. Recent onset disease may have few or no complication, while diabetes dying years earlier may have significant complications. So let's take a closer look at the multifactorial nature of hyperglycemia in older adults. At the center is diabetes in the elderly, influenced by a constellation of age-related and lifestyle factors. First, we have the age-related changes in glucose metabolism, which naturally impair insulin sensitivity and secretion. Obesity and sarcopenia, the loss of muscle mass, further contribute to insulin resistance. Reduced physical activity and an unhealthy diet compound the problem, often driven by limited mobility, social isolation, or economic constraints. Coexisting illnesses such as cardiovascular or renal disease and polypharmacy. The use of multiple medications can interfere with glucose regulation and insulin action. Longevity increases cumulative exposure to these risks, while genetics and autoimmune phenomena may predispose certain individuals to diabetes later in life. Taken together, these elements shape a challenging clinical scenario that requires careful, personalized management, and recognizing each contributor is essential for optimizing insulin therapy in older adults. So let us classify older adults with diabetes based on their functional status. This will help us tailor care more precisely. Category 1, functionally independent. These individuals live on their own and manage daily activities without assistance. They have no impairment in basic tasks like bathing, dressing, or personal care. The diabetes management can be more proactive and aligned with general adult guidelines. Category 2, functionally dependent. Here we see impairment in activities of daily living. Tasks like bathing or dressing may require help due to physical or cognitive decline. diabetes care must now balance safety, simplicity, and support, often involving caregivers. Category 3, end of life care. This group includes those with advanced illnesses or malignancy and a life expectancy of less than 1 year. The focus shifts from tight glycemic control to comfort, dignity, and minimizing treatment burden. This framework from the IDF Global Guideline reminds us diabetes care in older adults must be individualized not just by age but also by function. Now let's look at category 2, functionally dependent. These are older adults who need help with daily activities like bathing, dressing, or personal care. Within this group, we recognize two important subtypes. Subtype A, frail. These individuals show signs of fatigue, recent weight loss, and major limitation in mobility and strength. They're more prone to falls and often face a higher risk of being institutionalized. Frailty is now a recognized clinical condition and it affects up to 1 in 4 older people with diabetes. Subtype B, dementia. This group includes those with significant cognitive decline, memory loss, disorientation, or personality changes that now prevent them from managing their own care. They can no longer self-administer medications or follow treatment plans reliably. So understanding these subtypes help us adjust diabetes care, simplify regimens, prioritize safety, and involve caregiver more actively. Glycemic target in older adults vary by functional status. Functionally independent patients aim for A1C around 7 to 7.5%. Functionally dependent patients, including those who are frail or have dementia, may have more relaxed goals up to 8.5%. For those in end-of-life care, the focus shifts to comfort, avoiding symptomatic hyperglycemia rather than strict control. Now, in caring for older adults with diabetes, the ADA emphasized annual screening for cognitive decline, dementia, depression, and geriatric syndromes like frailty, especially in those with limitation in activity of daily life and instrumental activities of daily living. Hypoglycemia must be avoided. This means adjusting glycemic targets and medication to reduce the risk. Glycemic goal may be relaxed, but we still need to prevent symptoms and complications for high blood sugar. Finally, screening for diabetes complications should be individualized with special attention to those that impair function, like vision loss, neuropathy, or stroke. With regards to pharmacotherapy, in older adults with type 2 diabetes at increased risk of hypoglycemia, medication classes with low risk of hypoglycemia are preferred. Overtreatment of diabetes is common in older adults and should be avoided. De-intensification or simplification of complex regimen is recommended to reduce the risk of hypoglycemia and polypharmacy if it can be achieved within the individualized A1C target. Considered cost of care and insurance coverage rules when developing treatment plan in order to reduce risk of cost-related non-adherence. Now, when it comes to insulin, use with caution since clearance times may increase as GFR decline in elderly patients, thus it may cause hypoglycemia. Now, this is the algorithm to simplify insulin regimen for older patients with type 2 diabetes by ADA. However, it seems that this slide is so busy. So let me just simplify it with you. So simplification of complex insulin therapy that you can follow step by step, simplified basal insulin, mealtime insulin, as well as premixed insulin. For the basal, basically change the dosing from evening to morning. The mealtime insulin, if more than 10 units per dose, reduce by 50%, but add non-insulin agent, and if less than 10 units, you can stop and add non-insulin agent. For premixed insulin, use 70% of total dose as basal only in the morning. Patients should be monitored for hypoglycemia, glycemic target, and pharmacologic regimen may need to be adjusted to minimize the occurrence of hypoglycemic event. Now, to achieve the appropriate balance between glycemic control and the risk for hypoglycemia, it is important to carefully assess and reassess patient risk for worsening of glycemic control and functional decline. Glycemic goals for some older adults might reasonably be relaxed as part of individualized care, but hyperglycemia leading to symptoms or risk of acute hyperglycemia complications should be avoided in all patients. So when simplifying insulin therapy on older adults, the ADA recommended a few practical adjustments. No? Avoid short-acting insulin at bedtime. This reduces the risk of nocturnal hypoglycemia. Use a simplified sliding scale while adjusting mealtime insulin. For example, if pre-meal glucose is above 250 milligrams per deciliter, give 2 units of short-acting or rapid-acting insulin. If pre-meal glucose is above 350 milligrams per deciliter, give 4 units. Discontinue the sliding scale once it's no longer needed daily. This prevents unnecessary insulin use and simplifies the regimen. This step helps reduce complexity, improve safety, and support individualized care, especially in older adults with changing functional status. When older patients struggle with insulin or medication routines, we simplify the regimen to improve safety and adherence. If patient forgets meal insulin or has an erratic meal schedule, we shift focus to basal insulin for fasting glucose control. We can also use non-insulin agents like metformin, extended release GLP-1 receptor agonists, and SGLT2 inhibitors for post-meal glucose. If there are errors in insulin scaling, simplify with fixed doses or a two-step scale, for example, 2 units for glucose 250 to 300 milligrams per deciliter and 3 units for 300 plus blood sugar. If the patient has fasting hypoglycemia but daytime hyperglycemia, switch basal insulin to the morning and titrate to fasting goal. Add oral agent if needed. For those on a mixed insulin, simplify by giving 70% of the total dose as basal insulin, preferably in the morning. If the patient forgets oral medication, use once daily preparation, peer reminder devices, or a pre-poured medicine when appropriate. These strategies reduce complexity, lower risk, and support functional independence in older adults. So I'd like to go back to the two cases and try to answer what is the best treatment option for glycemic control on both of these cases, and should both patients be treated with insulin and to the same glucose target. But let's answer first the previous additional questions and later the case 1 and 2. The additional question is on your upper right corner. So when managing diabetes in older adults, we begin by assessing functionality. This includes activities of daily living, instrumental activities of daily living, cognition, comorbidities, and frailty. These guide our treatment goals. A1C target vary by health status. Healthy older adults, you aim for A1C less than 7.5%. Complex intermediate health, target A1C of less than 8%. Poor health or limited life expectancy, we can relax A1C to less than 8.5%. Intensify therapy when there is persistent hyperglycemia or acute complication like infection. De-intensify therapy if the patient has frequent hypoglycemia, high variability, or minimal benefit from tight control. Now, to streamline insulin therapy, let's go back and consider the two cases. In case 1, the central concern is glycemic variability complicated by cardiac and renal comorbidities. A practical approach would be to lower the basal dose or transition to a basal plus regimen. Case 2, the key issues here are infection, poor glycemic control, and progressive renal decline. Here, basal insulin at night combined with simple rapid-acting doses during meals, especially in a setting of infection. This can be effective. Thus, in case 1, we lean towards to the intensified therapy, especially the basal insulin, while in case 2, we intensify treatment by giving basal bolus, and this strategy ensures that care remains safe, effective, and individualized to each patient's functional and clinical profile. So with that, I'd like to conclude this presentation.